Thank you so much, Dr. Spitsnaz. As Cece mentioned, the CDC is just one of several federal agencies charged with implementing the strategies and plans that were just highlighted. And our next speaker joining us from CDC is Dr. Grant Baldwin, Director of the Division of Unintentional Injury Prevention at the National Center for Injury Prevention and Control at CDC. This division is dedicated to reducing the number and severity of unintentional injuries through science-based programs and applied research, and includes a focus on preventing prescription drug overdoses. We're so pleased Dr. Baldwin is with us today to share CDC's efforts.
Thank you, Catherine, and good afternoon, everybody. It's certainly a pleasure to be with you today. I will share with you the latest data on the public health burden of prescription drug and heroin-related overdoses, building on what Dr. Spitsnaz said. As she said, we're in the midst of an opioid epidemic, driven largely by the overprescribing of opioid pain relievers in the treatment of chronic pain. More recently, the sharp rise in heroin-related overdose deaths is a new and frankly not entirely unrelated development in an epidemic that's impacting every corner of our great country. I'll also briefly discuss two of CDC's signature initiatives to address the epidemic: implementing the Prevention for States Cooperative Agreement program and developing prescribing guidelines for primary care practitioners for the treatment of chronic pain outside of active cancer, palliative, and end-of-life care. As Cece said, here are details about Secretary Burwell's HHS initiative. She recently announced a targeted department-wide initiative aimed at reducing prescription opioid and heroin-related overdose, death, and dependence. It includes three priority areas, including 1, providing training and educational resources to health professionals, including developing prescriber guidelines to assist providers in making informed prescribing decisions and address inappropriate use of opioids. 2, increasing access and use of naloxone. And finally, expanding the use of medication-assisted treatments, such as buprenorphine and methadone, in combination with counseling and other behavioral therapies to treat substance abuse disorders. So what do we know now? More than 145,000 people have died from overdoses involving prescription opioid pain relievers in the last decade, and deaths have quadrupled since 1999. While opioid pain relievers can and do play an important role in the management of some types of pain, the overprescribing of these powerful drugs created this epidemic. Opioid pain relievers such as oxycodone, hydrocodone, and methadone are responsible for driving the dramatic increase in overdose deaths. The yellow line shows the fourfold increase in deaths since 1999. In 2013, over 16,000 people died from a prescription opioid overdose, or about 1 death in every 33 minutes. Notice the slight plateauing of the yellow line in recent years. Beginning in 2012, deaths dropped for the first time since the 90s. Nearly 1,000 fewer people died from a prescription opioid in 2012 compared to the year before. But that said, the data showcase another troubling trend, the recent alarming increase in heroin overdose deaths. When you look at the total impact of opioid use, a staggering number of Americans are impacted. In 2011, for every 1 overdose death involving opioids, there were 12 substance abuse treatment admissions, 25 emergency department visits for misuse or abuse, 105 people who met criteria for abuse or dependence on opioids, and 659 people 12 and older who reported using these drugs non-medically. 250 million. Providers wrote more than 250 million opioid prescriptions in 2012. This is enough for every American adult, all of us on this webinar, and the other 240 million Americans over the age of 18 to have our own bottle of pills. This is twice as many opioid prescriptions per person compared to our neighbors to the north in Canada. One driver of the increase in opioid overdose deaths is the abundance of supply of these very powerful drugs. This graph shows the relationship between the sales of opioids, the green line, and the number of deaths from them, the blue line. As you can see, as the amounts of opioids sold increased, so did the number of deaths. The supply of opioid pain relievers is larger than ever. The quantity sold in 2011 was 4 times that sold in 1999. There is wide state variation in overdose death rates. The darker the shade of blue, the worse the rate on this map. What is unique about this figure is that we've overlaid the opioid pain reliever sales rates on the map. The sales figures are the yellow bubbles. The larger the bubble, the greater the sales. While not perfect, note how the states with the highest death rates also tend to have the highest sales rates. If the 2013 national drug overdose death rate of 13.8 per 100,000 people was reduced to the lowest state-based rate observed in North Dakota, almost 9,000 more Americans would have been alive in that year alone. So who's at greatest risk for an overdose? Rates of opioid use and overdose death are highest among men, people in their working years of life, and non-Hispanic whites. Poor and rural populations are, in general, more likely to experience prescription overdoses. People who have a mental illness or a co-occurring non-opioid substance use issue are overrepresented among both those non-medically using opioids and those overdosing on them. So what is CDC doing about it? Well, we aim to complement the work of our sister agencies within HHS and focus on CDC niche activities. To this end, we have three areas of focus. They are improve data quality and track trends to monitor the epidemic, strengthen state efforts by scaling up effective public health interventions, and enhancing patient safety by supplying healthcare providers with data, tools, and guidance for evidence-based decision-making. Next, I'll outline our highest priority work, how our highest priority work is meeting these objectives. We are making a difference in states. This September, we launched the Prevention for States Cooperative Agreement Program. The program is a culmination of years of work with states. A total of 16 states were funded, an average of $875,000 per year for 4 years. States were selected based on a number of evaluation criteria. Most notably, states were competitively chosen based upon a high drug overdose mortality rate and their capacity to do something about the problem. We say at the intersection of burden and readiness. While states are required to implement some known effective strategies, and I'll talk more about those in a minute, the funding does give states the flexibility to tailor their work too. We've structured the PFS program to best advance two main goals: hone in on key, high-impact, data-driven activities that address the epidemic on multiple fronts, and provide states with the flexibility needed to tailor a prevention program that fits the problem in their state and reflects their judgment about how to tackle this complex problem. There are 4 priority strategies in PFS, 2 required and 2 optional. States are required to enhance and maximize their prescription drug monitoring programs and implement community or insurer health system interventions. This includes things like moving towards universal PDMP registration and use, having a real-time PDMP where a prescription is almost instantaneously added to the PDMP when filled, expanding proactive reporting to target high-risk inappropriate prescribing, and linking PDMP and health outcome data. An example of a health system intervention might include adding or strengthening the state's Medicaid PRR, or Patient Review and Restriction Program, where high-risk patients are limited to 1 doctor and 1 pharmacy for their opioid prescriptions. While not required, states can also advance policy evaluations. For example, evaluate a pill mill law or Good Samaritan law or other policy or regulation aimed at curbing the epidemic. Finally, there are the rapid response projects. This gives states the flexibility on a year-over-year basis to redirect and target a hotspot area or issue. As CC mentioned, the current fentanyl outbreak is a good example of what a state might want to use their rapid response project to address. Certainly, we're eager to document and track the impact of the program and prove that it's a best buy to the American people. To do this, we've created clear metrics about how we expect change to occur. We believe changes in programs and practices will lead to changes in provider and patient behavior, which will lead to changes in overdose deaths. Obviously, the ultimate goal for PDO-PFS are decreased rates of opioid abuse, decreased rates of emergency department visits due to misuse or abuse, and decreasing the overdose death rate. We know we can make progress because some states have already seen improvements by employing strategies like those outlined in PFS. For example, New York and Tennessee began requiring physicians to check their state's PDMP program before prescribing opioids. New York saw a 75% drop in patients who were seeing multiple prescribers for the same drug, so-called doctor shoppers, in 1 year. And Tennessee saw a 36% drop in the same outcome. On to guidelines real quickly. CDC is in the process of developing opioid prescribing guidelines for primary care providers for chronic pain outside of active cancer, palliative, and end-of-life care. Guidelines are needed to better align opioid prescribing practices in primary care settings, which can vary widely across the country, with the best available evidence to ensure safe, effective pain management. The guidelines will outline strategies for effective and safe use of opioids when evidence demonstrates their benefits outweigh their risks. I want to mention that these guidelines are non-regulatory and do not represent a standard of care. Rather, they give providers recommendations that can inform their prescribing decisions. All the while, providers will have ample room to use their clinical judgment and address each patient on a case-by-case basis. CDC elected to develop guidelines for a number of reasons. For example, right now there are only a small number of high-quality guidelines, and those that do exist have some inherent weaknesses. Among them, they're outdated and do not incorporate new evidence. Not all used a systematic and scientifically rigorous process in development. There are concerns about conflict of interest of some of the panelists, and none focused exclusively on primary care settings. The primary evidence informing the CDC guidelines comes from the AHRQ's systematic review on the effectiveness and risks of long-term opioid treatment of chronic pain, released in September of last year. This review rigorously addressed the effectiveness of long-term opioid therapy for outcomes related to pain, function, and quality of life, as well as the harms and adverse events associated with opioids. We updated this review with any new evidence that came out over the course of the last year. We developed the guidelines using the GRADE, or Grading of Recommendations Assessment, Development, and Evaluation method. This approach specifies the systematic review of scientific evidence and offers a transparent approach to grading the quality of the evidence and setting the strength of a recommendation. CDC is developing the guidelines using a rigorous and transparent four-step process. This included a core expert group, a stakeholder review group, public engagement, and peer review. The core expert group provided input on recommendation statements drafted by CDC to be included in the opioid prescribing guidelines. They met in late June. The core expert group included a number of primary care professional society representatives, subject matter experts, and state agency representatives. CDC selected members of the core expert group in a way to minimize conflict of interest, enhance objective assessment of the evidence, and reduce scientific bias. The stakeholder review group includes a larger group of 20-plus interested organizations that provided comments about the specificity, applicability, and implementability of the recommendations. In this group, there was representation from professional organizations that represent specialists by which opioids are commonly prescribed. The group also includes representation from community stakeholders and advocacy organizations. Next, public engagement was solicited through 2 webinars. This allowed for broader public input on the guidelines and for CDC to consider public perspectives. Finally, the guidelines were sent to 3 peer reviewers and will go through a formal internal clearance process, which they're doing now. To date, CDC has received 1,200 comments and made 350 substantive changes to the guideline recommendations or the supporting text. The guidelines will be released in January of 2016, and broad dissemination is planned. The guidelines are still in clearance, so I'm a little bit limited in what I can share. I will say that they address the determining when to initiate or continue opioids for chronic pain, opioid selection, dosage, duration, follow-up, and discontinuation, and assessing risks and addressing harms of opioid use. At the broadest level, 3 take-home messages for the guidelines will be the following. Non-opioid therapy should be preferred for chronic pain outside of end-of-life care. When opioids are used, the lowest possible effective dose should be prescribed to reduce the risk of opioid use disorders and overdose. As one of my colleagues puts it, start low and go slow. Providers should always exercise caution when prescribing opioids and monitor all patients closely using PDMPs and other means. In summary, overdose deaths from prescription drugs and heroin are at epidemic levels in the U.S. We have a better understanding of the drivers of the epidemic and the importance of addressing prescribing. A multifaceted and multi-sector approach is needed to achieve more progress, and interventions must be evaluated to determine the effectiveness and need for state-specific adaptation. Thank you very much, and I look forward to the Q&A, and let me turn it back over to Catherine. Thank you.